Yeah, that we usually Hello, and welcome to the monthly Care Partner Training. This month, we're talking about dealing with difficult behaviors, and our presenter is Bridget Reynolds, clinical coordinator and nurse practitioner. Our mission here at Insight is to provide specialized care, support, and education for individuals in all stages of memory and cognitive impairment, their partners, and the community. A community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. We are a leader in dementia care in Northern Virginia. Insight is a nonprofit started in 1984 that supports families on their dementia journey. Care, we specialize in adult day programs for people in all stages of the dementia journey. We connect by building relationships and support care partners on their journey. And with creativity, our dementia experts share their knowledge and resource because every journey is unique. We support families on this journey. Insight's a nonprofit that relies upon the generosity of people like you to engage people with dementia and support their care partners. One of our family members said, I support Insight because I think this is one of the premier organizations to help people with dementia and their caregivers. I'm extremely impressed with their staff and the services provided. Bridget Reynolds joined the Memory Disorders Program in 2001. She received her Master of Science in Nursing from the Catholic University of America and a Bachelor of Science in Nursing from Emory University. Bridget is certified by the American Academy of Nurse Practitioners. Prior to joining the Memory Disorders Program, Bridget's career focused on home care, primary care, and case management for elderly patients. Presently, she's on faculty at Georgetown University, where she specializes in evaluating and treating patients with memory problems and is a research investigator conducting clinical trials of potential new treatments for Alzheimer's disease and related disorders. Throughout the presentation, if you have any questions, please put them in the Q&A for those of you online. For those of you who are in person, can raise your hands and Bridget can answer them. So we thank you all for being here and welcome to Bridget.
Dance, obviously, let's slide 174. You got this? Hello, everybody. It's great to be here today. As Melissa mentioned, I'm Bridget Reynolds. I'm a nurse practitioner with the Memory Disorders Program. And I have been with the Memory Disorders Program since 2001. And this is a picture of our team at the Memory Disorders Program at Georgetown University.
Okay, we are all set. Sorry about that delay.
I can appreciate that. It's happened to me.
Well, it can be especially hard to do the hybrid and in person with the Okay, so this is our team. We have 4 nurse practitioners, we have 4 coordinators, a regulatory coordinator, and 4 MDs. And again, what we specialize in is evaluation of people with memory loss or cognitive changes and research. We are testing new treatments, clinical trial research for Alzheimer's disease and related disorders. All right, so disclosures. I've been a board member at the Insight Memory Care Center since 2017. I was a contributing author to the 5th edition of Caregiving at a Glance, a fingertip guide to caring for a loved one with memory impairment. Of course, that is an IMCC publication. I'm going to be talking later about the Libby study, and I am co-PI of the Libby study. And I'm also a Libby study sub-investigator at Georgetown University. The sources for this talk, I used 2 books that are small books, both of which can be ordered on Amazon. Becoming an Alzheimer's Whisperer, a resource for family caregivers. I heard Dr. Carson speak years ago and was just so impressed with her techniques and approach to communications with Alzheimer's disease and other dementias. Of course, Caregiving at a Glance is the fingertip guide, an IMCC publication. Its last edition was in 2019, and special credit here to Lynn Simon, who was the initial author of this way back in 1991. And then I used references from ADIR, which is the NIA website. I'm going to talk a little bit more about in a minute. The Alzheimer's Association 2023 Facts and Figures has a lot of statistics about Alzheimer's and other dementias. They update that every 1 or 2 years. The Alzheimer's Society webpage and the Alzheimer's Association webpage. In particular, throughout my career, I've had a particular passion for behaviors and having a better understanding of the causes of behaviors, and especially a commitment to working towards, with my colleagues, the development of better treatments for behaviors in Alzheimer's disease and related disorders and other dementias as well, although other dementias are not so much the specialty of our clinic. But at Georgetown University, we have we have many neurologists and a strong research program and clinical care program for not just Alzheimer's disease, but all dementias. So I'm going to be talking today, I'll start by talking about some of the resources that are available. I'm going to be talking about the brain and behavior, and then caregiving and the impact of behaviors on caregiving, communication, which is arguably one of our strongest, most effective techniques for dealing with behavior, a little bit about medications for treatment of behaviors, and then I'll address some behaviors specifically, including agitation and aggression, sundowning, paranoia, and specific and suspicious behaviors, wandering, and apathy. And then I'm going to conclude by talking to you about a new study that we are doing, that an NIA-funded study that is examining THC-CBD combination for education at the end of life in dementia. So resources, there is lots of information online for caregivers and to support caregivers. And my favorites throughout the years, some of my favorites have been the Alzheimer's Association, of course. And their website is there. ADIR, it stands for Alzheimer's Disease and Related Disorders Education and Referral Center. This is the NIA website. And from the NIA website, you can either download PDFs or you can order printed copies of their informational brochures. And then I also use the website. I also want to point out dementiacarecentral.com is another website which has a lot of support services and information for caregivers. All right, so behavioral symptoms and dementia. First of all, behavioral symptoms commonly occur in all types of dementia, and they also occur at all disease stages. They tend to be gradual in onset, and so if you have a sudden onset of new behaviors, one thing you definitely want to consider is the possibility of delirium. And delirium is when there's a sudden change, a sudden and acute change in behaviors and cognition. And usually some of the most common causes of delirium are changes in medication, changes in environment, or infection. So all of these things can contribute to new behaviors, but if you see a sudden change, often it may not be related to the dementia itself, but more related to something else that can be addressed. Communication strategies and lifestyle and behavioral interventions are often the most effective tool for the management of behavioral symptoms. And we'll get into this a little bit more when we talk about medications and management. But it's remained true for as long as I've been involved, which is really my entire career, even before I came to Georgetown and working with people with dementia and their caregivers, that it's not the medications that are usually we get the most mileage out of still. And we need a lot more research and the discovery of better medications for the behavioral symptoms in dementia. So I'm starting with mild cognitive impairment. I'm going to go a little bit, I'm going to be talking about the brain, and I also want to talk about some of the earliest stages of memory loss and cognitive changes along the dementia spectrum, because behavioral symptoms start, even in some cases, definitely in many cases, before a diagnosis is made, but often even before dementia. So mild cognitive impairment is a condition where people have memory loss that's beyond what's expected for their age, but it hasn't led to interfere with daily activities. So the difference between mild cognitive impairment and mild dementia, any type of dementia, is that the people have cognitive and thinking changes, but they're still able to do everything that they were once able to do. It may take them longer. They may need a little more support, but they're not making mistakes, and so they basically maintain their function. And mild cognitive impairment, not everybody with mild cognitive impairment goes on to develop dementia or Alzheimer's disease, but they're at greater risk. So if you have mild cognitive impairment, it's another risk factor for the development of Alzheimer's disease or dementia. And of course, the greatest risk factor for the development of Alzheimer's disease or dementia is age. A question that I am always asked is, what is the difference between dementia and Alzheimer's disease? So I include this in every talk that I give, where dementia is a set of symptoms characterized by a decline in intellectual function that impacts one's functional and social activities. So again, dementia is kind of an umbrella term. It is an umbrella term. It's not a diagnosis. So if you've been given a diagnosis of dementia, you really should be asking what type of dementia. And so here again, you see the difference between any dementia and mild cognitive impairment is that functional piece. So again, think of dementia as an umbrella term with Alzheimer's disease being the most common form of dementia. And then, of course, we have vascular dementia, we have mixed dementia, Lewy body dementia, frontotemporal dementia, and then all of these other types of dementia. But by far, Alzheimer's disease makes up about 60% of all the dementia. So it's the most common form of dementia, but by no means the only form of dementia. All right, another thing about Alzheimer's disease, I'm often asked, so the rising prevalence of Alzheimer's disease, and which age group is this occurring in? And so I think we're doing a better job at diagnosing younger people. So you can see people aged 65 to 74, and we often diagnose people younger than the age of 65. Anybody below the age of 65 or 65 and younger is considered early onset dementia. But that group is not rising too significantly between 2020 and 2060. The incidence overall of Alzheimer's disease is expected to more than double between 2020 and 2060. But the group that's rising the fastest are the people that are 85 plus. So, and you can see pretty much by far the fastest. These are and this of course is because of the graying of America. People are living longer is one of the reasons. But along with the fact that people with 85 plus also tend to have more sensory impairments, and all of these contribute to behavioral symptoms. So we really have to work on better ways and strategies to manage behavioral symptoms, because we can assume that the numbers of people that are going to be needing help are going to rise dramatically by the time 2060 rolls around. Again, looking at different kinds of dementia, Alzheimer's disease, about 62%, vascular 17%, mixed dementia, I think is probably more common than 10%. There's overlap between the dementias, and if you actually examine the brain tissue of people with dementia, you'll often find significant overlap. Dementia with Lewy bodies, smaller group, 4%, frontotemporal dementia, 2%, and then Parkinson's dementia. And behavioral symptoms, it can be a very important tool for us to make a diagnosis of which type of dementia the patient is experiencing. And the reason is, depending on where the pathology is in the brain, sometimes behavioral symptoms are more pronounced than memory loss and thinking changes in certain types of dementia, like often frontotemporal dementia is one of them. Huntington's disease, lack of insight is very common early on. So in order to make a diagnosis, the behavioral component of it is very important, equally as important as what cognitive changes have been noticed, what functional changes have been noticed, and what behavioral changes have been noticed. We call that the ABCs: activity, the function, behavior, and cognition. All right, so I'm going to link behaviors directly to the human brain. Challenging behaviors are directly linked to brain disease or pathology. There's a link between behaviors and damage to specific brain areas. Behaviors may seem deliberate or purposeful, but it's not. Most of the times, these are related to the disease process. And people with dementia commonly lack insight into their symptoms and may be unaware of the impact of their behaviors on others, which can be particularly challenging for caregivers when someone, a loved one of years, doesn't recognize the impact of their behavior on them. And so it's oftentimes lack of insight is confused with denial. So the person just doesn't want to accept this, but oftentimes it's not that. It's that they don't, because of the disease, they're not able to understand what's happening or perceive it. And again, I think somewhat of a glaring example of this is Huntington's disease, where people can have choreiform movements, jerky movements, that anyone that's looking at them would be like, oh my gosh, how can you live with that? That must be so difficult. And they're unaware of the movements. So here's this, I think it's important, we'll show a picture of the brain. So we have, of course, the frontal lobe, and this is where many behaviors are concerned, and this is why with frontotemporal dementia, you do see behavioral symptoms early on. The temporal parietal lobes, so basically you have the temporal parietal lobes in this part of your brain, affecting memory and speech and language. The occipital lobe is actually at the back of your head, and this is where visual processing occurs and processing in general. Then here we're gonna talk about, I wish I could have had a slide, or I was good enough to like throw in the different cognitive aspects of these areas of the brain, but we have the hippocampus. That's one of the areas of the brain that shrinks early on, begins to shrink early on in Alzheimer's dementia. And of note, all of our brains begin to shrink while we're in our actually late 20s. But the hippocampus is where short-term memory stores short-term memory, and so the impact of a shrinking hippocampus is progressively limits new learning. The frontal lobe, we can consider that like the brain's behavioral headquarters. The parietal lobes, spatial processing, orientation, navigation. The temporal lobes, time awareness and language. Occipital, visual, and conceptual processing. There's a type of dementia called posterior cortical atrophy, where the amyloid plaques tend to accumulate in the occipital lobe, and those people have difficulty seeing objects right in front of them early on in the disease, earlier than you would expect in other forms of Alzheimer's, posterior cortical atrophy being a variant of Alzheimer's disease. The motor strip controls our walking, sitting up, these basic life functions, continence and swallowing. Limbic system, another emotional roller coaster, controls our emotions, and the hypothalamus controls temperature and appetite. So again, I mentioned behavioral symptoms in dementia occur very early on, and I think that's why I wanted to cover something about accepting the diagnosis. So decisions who to discuss the diagnosis with, whether or not, telling others about the diagnosis can be difficult and anxiety provoking. Unfortunately, there's still a lot of stigma associated with dementia and Alzheimer's disease. And caregivers and patients who are people earlier on in the stage of dementia, they're unsure of who to tell. I recommend telling people who you think can be a support. God bless you. Sharing the diagnosis, even though it can be difficult, can be empowering, and it can open up new relationships and sources of support. You want to prevent isolation, like keeping this a story to yourself. You need to ask for help from others. Allowing time to process, grieve, and mourn are an important initial step in adjusting to a new diagnosis. You can't just like breeze by it. You have to be able to feel those feelings in order to move on and move forward. We talked a little bit about denial versus lack of insight. This can be a problem in accepting the diagnosis. Caregivers have to understand that in many cases it's not purposeful denial of the loved one that they're caring for, but it's really lack of insight, and we'll be talking about tips to sort of deal with that. And I also want to say that, well, I'll get into that later. So maintaining a sense of self and discovering purpose is important for someone who's recently diagnosed to really think about what's important to them and what they would like to continue with in their lives. I always encourage people to think less about what they can't do and more about what they can do. Capitalize on strengths and explore options. What's something that you would like to do? What's something that we can do together? And then figure out a plan as to how to accomplish that. Certainly learning about the diagnosis and support services. I feel very strongly that knowledge is power. And there are a lot of resources out there in order to learn about Alzheimer's disease and support services, such as support groups and memory cafes and counseling and so on. And most importantly, as always, throughout your life, engage in healthy lifestyle interventions. And some of the most effective tools we have to target and treat the behavioral symptoms of dementia, again, are remaining as active as possible, keeping your mind active, staying physically active, and social engagement, staying socially engaged. And very important to discuss treatment goals with family and medical providers. I'm aware that Insight has a program called the SHARE program, and some of you may have been involved in the SHARE program, but I think it's a very important to be able to, for both people, the patient, the caregivers, their family, to talk about what it is, what their expectations are for the future, and to make a plan. And the SHARE program provides an opportunity for that to happen. That's just one example, but discuss the goals with the treatment goals and lifetime goals with family and medical providers. So these are some statistics I pulled up on caregiving and behavior, and I did get this from the 2023 Alzheimer's Disease Facts and Figures report. It's important to know that unfortunately there is a lack of research on this topic, and there's a lack of recognition on this topic. But I'm seeing and noticing that there's more attention being drawn to it. And that's very important because we need to better understand, for every person with dementia, there's someone that's caring for them, of course. And we need to better understand how we can take care of the caregiver, because the caregiver can't take care of the patient unless they are taking care of themselves. So caregivers for people with dementia who have 4 or more behavioral and psychological symptoms are more likely to report clinically meaningful depression and burden. Caregivers of people with Alzheimer's disease or other dementias who provide help alone are more at risk of social isolation. So that may seem obvious, but it's a very important point to bring up, because social isolation contributes to added burden and stress and depression for the caregiver. Population-based sample of caregivers found that although dementia caregivers indicated greater strain than non-dementia caregivers, there was no substantial difference in strain between white and Black caregivers, dementia caregivers. The number of self-care, so functional and behavioral problems, was most predictive of caregiver burden and depression, regardless of whether or not the care recipient lived with dementia. So again, it's the functional impairment and the behavioral impairments of the patient or the person that are most predictive of caregiver burden and depression and depression. And then finally, these are just some of the statistics that I found most interesting, but there's a bunch more on the Alzheimer's Disease Facts and Figures. So I encourage you, to take a look at that if you're interested on the topic. They have, an entire chapter on caregiving and statistics. But finally, among dementia caregivers, care recipients who had experienced severe psychiatric symptoms, those who live in low and medium income households indicate higher distress than those caregivers living in high income households. So this is something that we need to learn more about. Why is that? Is that strictly financial? Is that because of access to support services in different areas of the region, the country? So again, many of these points pointing towards the need for more research. So what to try as a caregiver? I base this what to try based on the Insight pamphlet book on caregiving. So that's kind of the way I designed this presentation. So on each topic, we'll talk about what to try, not what to do. One of the things that's hard with this presentation is a lot of the times, it may seem to caregivers like, well, that's easy for her to say. There is no one size fits all, and recognizing the significant burden that caregivers are in, some of these suggestions may not always be practical, but I think the most important one, which is why it's in yellow here, is to take care of yourself, because you can't take care of someone else if you don't take care of yourself. And I think caregivers as a group, it's easy to lose sight of this because of all that there is to do for the loved one. So it's important to stay and get your regular medical checkups, ask for help. Keep a list of tasks requiring assistance. So many times caregivers will tell me, someone might say to them, I'm here, I'm here, I'm available to help. What do you need me to do? You need to be prepared to be able to tell people, be specific and don't be shy about it. Maybe it's something like, okay, could you come over and have lunch? It would give me a chance to go out and do some grocery shopping. Could you go for a walk? And setting a routine is helpful. Like if someone could commit to helping every Wednesday, for example, so that the caregiver can plan, but don't be shy about it and be prepared. Keep up with hobbies and activities that give you pleasure. Stay in contact with friends and family members. Don't try to do this alone. Choose the friends who you think can be a support to you. Let them know how you're doing. Educate yourself. We talked about that. Learn about the disease process and support services in the area. Accept the fact that sometimes you may be angry, resentful, or feel trapped. I mean, that's got to be, I know that's very common because this is such a huge task. It can be such a huge task to care for someone with dementia. Take breaks, establish a routine, try and do one thing for yourself every day, even if it's something simple, like sit down, have a cup of tea, read the book that you haven't had a chance to get back to for a long time. And of course, join a support group. Consider joining a support group or a memory cafe, both of which are available here at IMCC. So getting into communication, the 4 R's when it comes to behaviors. Number 1, reassess. You want to know, is there a reason that you can identify that's causing, for example, agitation? Is there a physical reason? Pain is a common cause of frustration and agitation. Is the person in pain? And of course, these tips vary based on the degree of dementia. When someone has severe dementia, you almost have to become a detective. You have to really observe body language and nonverbal cues for people who are not able or less able to speak. Redirect. Suggest another activity. Distract, change the topic. And this is, I think, important too. It's okay to lie. So to prevent escalation of behavior. So for example, if someone insists they need to wait because their mother who's passed away years ago is coming over, they need to do that. It's okay. I understand, but I don't think she's expected right away. Why don't we go out for a walk? You don't challenge them and say your mother died years ago. But it's more, and sometimes caregivers feel like they need permission to lie. You don't need permission to lie. It's okay if it will help prevent escalation. And provide reassurance. I know that must be sad for you, but I only have a few minutes here, or we have a few minutes. Maybe it would be helpful if we started cooking dinner or something. Like, so you're reassuring them, validating, not dismissing, but reassuring, and be tender. The power of touch can be very strong. And then finally, rethink. Try and think of the situation from the individual's point of view. Now, Melissa, you may know, I know at Insight, they had that room where people could put on gloves to get the feeling of neuropathy. And
So that's our VDT program, and we do that all around the community.
yeah, so I did that once, and I found that to be it had a big impact on me. So it's like, because that kind of program forces you to put yourself in the person with dementia's shoes. Yeah.
Could you explain that again?
So it's called Virtual Dementia Tour.
Okay.
And we take away some of your senses and give you a list of tasks to do, so that you can experience what it's like to a degree of what someone with dementia has, while having these sensory pieces disturbed. We're actually doing one. The slots are filled next week. We are doing one out in Vienna, but if you keep an eye on our calendar, we do them multiple times throughout the year. And it's an emotional experience, but it's a great way for someone to understand how your loved one's going through this journey.
Yeah, so it'll say something like, go find the pink sweater or something. It's difficult. So, but it's an example of an effort to help people understand what it would be like to have dementia. All right, so when I was going through this is from the ADIR website or the NIH website. These are some of the do's and don'ts of communication, but I really felt like so much of this also definitely applies to the provider who's working with someone with suspected dementia or dementia and their caregiver, because oftentimes, for example, do make eye contact and use the person's name. Do listen and be open about the person's concerns. Allow time for the person to respond. Try using different words if the person doesn't understand what you say to them the first time, and ask yes or no questions. Would you like some tea rather than what would you like to drink? So I think I'll often hear, unfortunately, people will come to us who've been evaluated, had multiple evaluations, and we still don't have a diagnosis. And in particular, the patients will often comment that they felt like they were left out of the conversation. So providers and caregivers need to stay away from doing that. And like, for example, the last one, would you like some tea, with the main mental state exam, which is one of the most common cognitive tools that we use. You'll instead of saying, do you know the date, it's what is the date? Because if you say, do you know the date, it could be immediately challenging to the person. The don'ts, and these are, again, I just found this, I found this very particular to providers as well. Don't exclude the person from the conversations. We ask to have two people come to every visit, the patient and the caregiver, because that's the best way we can find out what's happening, both from the patient and from someone who knows them well. Of course, don't speak in an angry or tense tone. You're going to be angry sometimes, not so much to the providers, but maybe it's better to take a break and then come back. Sometimes you're gonna need to take a break from the situation. Don't talk about the person as if they're not there. Include them in the conversation. I have had, it can be so much easier to talk to the person without cognitive impairment that it's easy to sort of be a little bit dismissive. God bless you. Don't interpret or argue with the person. You're not going to be able to talk them down if they have a false belief. So it's very important. Come on, how did you think that? Don't you remember that just yesterday XYZ happened? That's not true. Don't do that. Change the topic, redirect, reassure. I know that must be distressing to you, but is there something, not is there even then, but why don't we, keep things simple and give simple suggestions? And so again, don't ask the person whether they remember. Don't you remember? Don't. All right, medications. There are very few FDA-approved medications for the treatment of behavioral symptoms in dementia. So the medications, not to say that we don't use medications to treat behavioral symptoms, but the pharmaceutical interventions are used off-label. So for example, in depression, they're approved for the antidepressants may be approved for the treatment of depression, but they're not approved for the treatment of depression in dementia. So these behavioral symptoms are different. Depression is different in dementia than it is as a diagnosis of depression alone. And key points, always consider non-pharmacological interventions first. Start low and go slow. With any of the medications, and this is more of a provider tip, but something that, the patients and caregivers can question the providers too. You typically start with the lowest dose and lower for an indication such as depression, and gradually increase the dose to determine tolerability. avoid multiple medication changes at a time. It can be very confusing if someone's gonna develop a new side effect, if multiple medications are made to determine which medication is the cause of the side effect. Overall, over-the-counter medications and supplements have potential side effects. So this one I like to talk about most is the over-the-counter sleep aids. So they're the first thing many people turn to. They're always labeled as some kind of a sleep aid, but it's what is in the ingredients. So the antihistamines that are in the over-the-counter sleep aids tend to be bad for people with dementia. They cause worsening memory problems and increased risk of falls and so on. So Tylenol PM, for example, what makes it different from Tylenol? It's that PM, which is typically an antihistamine, not a second generation antihistamine, which are non-drowsy, so they wouldn't be effective for sleep. So it's just important to don't assume that over-the-counter medications and supplements are universally safe. Check the label and see what is included. What are the active ingredients in the drug? And then finally here, alcohol is a drug. This is very important. Alcohol is a drug. We metabolize alcohol differently as we age. So it's really, I know there's been some studies that have shown that small amounts of red wine can help with preserving cognition, but alcohol in excess is really universally bad for everybody, and also especially for people with dementia.
Can I ask a question? What about my husband likes a glass of red wine at dinner time? That also combined, a large glass of red wine. Then the sundowning, and I've seen his behavior change. He gets more agitated when he's had a glass of wine in the evening. And also, I wanted to ask about the sleep aid. What about melatonin?
Melatonin, natural hormone, yes. And
That's okay.
over the counter, yes.
Okay.
They recommend melatonin. It's one of the early things to try to help with sleep. With the alcohol, you want to limit it to 1 to 2 6-ounce glasses of wine per day. But with sundowning, and if you're noticing in particular that it's 1 to 2 6 ounces, that is not a big glass of wine. So you probably one of those big glasses is probably more like 12.
No.
They sell non-alcoholic wine. That would be my magic trick.
Well, the thing is, he's aware of everything right now. And so for me to tell him that is like, you're not my mother, I can have I enjoy a glass of wine.
It can help
because he knows things are changing. He's very aware of everything's changing.
Yeah.
He doesn't like me to say anything because he is aware of it.
Yeah.
So he would, for me
help.
to say not to have a glass of wine,
Yeah.
really.
I think it would be maybe going too far to say not to, but to say, this is where you can rein in the provider with help too. So you message the provider and say, hey, this is, they need to know how much drinking is going on, and say, I could really use your help to say, this is dangerous for you, and I want you to limit this to not more than 1, say 8-ounce glass.
Because he just felt comfortable even driving here. We live in Fairfax Station, which is 20 minutes or half an hour. And he just quit on his own after me talking about it, and just because he didn't feel comfortable, and because he went to the farmer's market, forgot where it was. He said, I'm not going to hurt anyone. I'm done. I'm not doing it anymore.
Well,
And
he
the
quit
doctor
the
had said,
program.
pardon me?
What did he quit?
The
Driving.
Oh,
Because he was still, he's aware of things that are happening. And he did that on his own, because when we saw the neurologist, he said, well, you could go to the farmer's market, you could go to the public library within 10 miles, as long as you feel comfortable, but he on his own decided he didn't feel comfortable, and that was a good
That
thing.
is so good.
So,
that is
so it's hard to tell him anything because he's aware of a lot of it.
Yeah, and there can be some things that are harder. It's just like for all of us, some lifestyle intervention changes that are harder.
Some
for
strange
him
things
than
like not being able to button a shirt, hanging up clothes if you don't really put 2 arms in a hanger, things like, he notices that.
So, and being aware of mistakes like that can be a source of increased frustration for some people, where it's just
Absolutely.
lack of insight.
Or forgetting your jacket everywhere, forgetting things, Sorry, I had to ask that about the alcohol.
Oh, no, good question. So what to try? Keep a list of medications, including dosages and stop dates. This is really important. Polypharmacy or people taking too many things because unfortunately, our electronic medical record systems don't always communicate. So one provider provides something, someone something else, and the other doesn't know how to prescribe. So keep a list, keep it in your wallet, bring it to all medical appointments, and it's important to know the dosages that they're taking when they started and if they stopped it. Ask about a medication's purpose and potential side effects. Know what you're taking. Why is this being prescribed, and what side effects might I notice? Question the need for more than one medication at a time. Ask if medications can be crushed or come in a liquid form. You don't want to get home with a pill form of a medication, but for a person who has difficulty swallowing. Ask about the onset and duration. Some of the antidepressants, for example, take up to 4 weeks to notice any effect. You want to be prepared for that. Provide supervision, even in the mildest stages of memory loss. People can need assistance with administration and with medication administration, and the degree of supervision varies depending on the disease severity. And in many cases, especially in the earlier stages, you want to keep the person involved. You don't want to take them out of it, but you want to provide supervision. And pill boxes can be helpful and help to prevent forgetting.
Just a reminder, if anyone online has questions, please put them in the Q&A. Thank you.
All right, this is the first approved, Rexulti was the first approved medication for treating agitation in people with Alzheimer's dementia. And I won't go too much into this, but just to say this was just approved in 2023. It's still very expensive. It's not off patent. We don't know, in terms of insurance companies and coverage, but it's just an example. There are very, very few FDA approved medications for the behaviors in dementia.
And this is FDA approved.
Mm-hmm. The first
But when you
one.
see the ad on TV and they mention stroke and death, and my husband's looking at that.
Yes.
He's reading that and he's saying, I'm not doing that.
It doesn't mean it doesn't have potential side effects. Yes, right. Agitation and aggression. Agitation, one of the most common and challenging aspects of care among patients with dementia. Some of the causes for agitation could be pain, other medical conditions, infection, metabolic abnormalities, drug interactions, sensory problems, hearing or vision can contribute to agitation. A recent experience, especially things like hearing loss. If someone's not hearing a conversation and then they jump in, they say something inappropriately and then feel embarrassed because it didn't fit the conversation or maybe unaware of it. Environmental changes, we talked about that, really sudden changes, and in particular, you want to look for environmental medication or medication changes or infection. Misperceived threats, so people can be confused about something that's happening, and that can lead to agitation or fear and fatigue. They're tired of dealing with all that they're facing.
We have a question online. Could you please address how to handle keeping a patient safe when they have agnosia, and how best to address communicating without coming across as their parent?
So can we hold the questions until the end? Because I think we're at, and then remind me of that.
Yeah.
One, because I'm afraid.
No problem.
So what to try? A medical evaluation, particularly if agitation comes on suddenly. Try to understand the cause and adapt the caregiving environment to improve the situation. Create calm. So sometimes agitation can be caused by too much stimulation or not enough stimulation, but generally a calm environment and maintaining routines, offering simple one-step tasks. If you tell someone 3 things to do and they're only going to remember the first, they're going to become agitated. Oh my gosh, why can't I do this? Mm-hmm. Allow for rest between stimulating activities. Discourage engagement in stress-provoking activities. We always say this with cognition too, tell people to remain cognitively active. That is with activities that they enjoy, not that activities that they find stressful, because that's going to be a source of frustration. Try to identify the triggers for the agitation. Does it occur at a certain time of day? Is there some person or thing that seems to trigger them? Redirect, reassure, and empathize. Same thing, communication tips. Offer simple choices. Don't shout and don't argue, and don't be offended. Someone's not agitated because of you. It's part of their disease. And safety and prescribing agitation and aggression. The safety of the caregiver and patient are a top priority. You want to be sure, especially with people that are having aggressive behaviors, to remove or lock or put away dangerous objects, guns, knives, household chemicals. And to call 911 if there's a threat to yourself or to the patient. And then the typical medications that are commonly used for the management of agitation and depression, aggression, antidepressants, antipsychotics, and anti-anxiety medications are commonly prescribed. Sundowning occurs at all disease stages. It's common in the middle and late stages of dementia. It results in increased confusion, anxiety, agitation, and disorientation. So sundowning is when people become confused and agitated, typically in the late afternoon, but it can extend into the evening. And it can be impacted by things such as fatigue or the change in lighting. I think for sundowning, especially too, when there's a clock change, it can be more of a problem. And increased shadows may contribute. What to try: plan more active days, restrict caffeine consumption to morning hours. Melatonin can be tried for sundowning. I've just said that when we get to the medications. Limit late afternoon and evening activities to simple and relaxing. Keep distractions to a minimum. Allow pacing while monitoring for wandering. So someone who pacing is very common in Alzheimer's and other dementias, or can be. It's okay to pace. It really is, as long as you're monitoring and making sure they're not pacing out the door. As long as the person isn't agitated, they can be pacing. Plan outdoor activities such as walking during daylight hours. And for sundowning, again, we use a medication called trazodone frequently, which is an antidepressant, but not often used for depression. Other antidepressants and anti-anxiety medications may be prescribed, all of which are prescribed off-label. And melatonin can definitely be helpful to sleep. Paranoid and suspicious behaviors, they're more common in the middle and late stages of the disease. A person with dementia may see or interpret things incorrectly. Delusions are persistent false beliefs, so sort of separate. Often delusions can be paranoid delusions, or sometimes they're not. And we don't treat behaviors that are not disturbing to the patient or the caregiver. We just it's okay to let that happen if the delusion is not, if it's not bothersome to the patient. So the delusions and paranoid suspicious behavior can be due to misplacing objects, forgetting where things are placed. So, if you don't know where it is, it's easy to think that someone else may have taken it. If you, not later in the disease stage, not recognizing the caregiver or others whom they once knew well, I personally can't imagine how frustrating it would be if I was with someone who I didn't recognize and they were one of the only people I was with most of the day. Misunderstanding instructions, so making mistakes and then thinking that something else happened. So, and confusion about the circumstances is, it's a form of disorientation that can lead to paranoid suspicious behavior. So what to try? First of all, don't take offense. Listen and try to understand the person's reality again. These communication topics keep on coming up. Be reassuring, let the person know you care. Don't argue or talk down out of paranoid, or don't tell them that's wrong, that didn't happen, no way. And don't try to reason with them. How could that have happened when XYZ? Offer a simple answer or explanation. It's okay if it's untrue. Redirect to another activity, or such as asking for help with the chore. Make sure you lock away potentially dangerous weapons. People who are paranoid and suspicious may also often lack judgment. And antipsychotics are most commonly used for the treatment of psychosis, which paranoia and suspicious behaviors are in dementia. And of course, again, off-label. Wandering commonly occurs at some point during the disease. 6 in 10 people with dementia will wander at least once. Many do so repeatedly. Particularly stressful for loved ones. Obviously, there are significant safety concerns, worry, they may feel trapped by constantly having to monitor someone, tired of watching someone who's constantly on the go. Wandering may be due to feeling like the need to get somewhere, such as a job, or to an appointment as though they're still working. And one I see the very common one is searching for home. And I view this, it's just kind of home is where you feel content. And so often people that are wandering, they don't recognize their home as their home, and they may be trying to get back to home or just to get out. So what to try? National wandering prevention programs such as the Alzheimer's Association Safe Return Program or Project Lifesaver. Consider a GPS or tracking device. These can be helpful, but not if the person forgets to wear it. Make a plan or steps, have a plan in case someone gets lost or has a fall. Inform the neighbors about the possibility of wandering and let them know how they can help. Telling the person with dementia to stay put isn't going to work in the advanced stages. They're not going to remember what you said, and they're more than likely going to want to go off and try to find you. Provide a safe wandering space. Hang bells on doorknobs and use child-resistant knobs or covers on doorknobs. So that's a way to alert you if the door is opening. Place locks in unusual places, such as high or low, where they won't be immediately seen. Dress the person in bright clothing, especially when they're in crowded places, so that they'll be easy to find. Apathy, this is a real tough one, also common. Apathy is where there's little or no motivation to do things that were once meaningful and worthwhile. About 2 to 5% of older people have apathy, but about 50 to 70% of people with dementia will experience apathy. It can occur in any type of dementia. It's particularly common in frontotemporal dementia, more common in the later stages of the disease, but can also start early, especially in certain types of dementia, like frontotemporal or Lewy body or Parkinson's dementia. And the difference between apathy and depression is that people who are apathetic, they lack the symptoms of low mood. So they just don't care. So they're not sad, they just don't care. So they tend to lack sadness and helplessness. Instead, they just have little energy or no spark. And so some of the symptoms have no energy, no spark, rely on other people to suggest and organize activities. They're not interested in joining conversations or talking to people. They tend not to be worried about their own problems. And they lack emotional response to news or personal events. Medications typically play a small role in the treatment of apathy. It's even less well studied than symptoms such as anxiety and depression. Stimulants or antidepressants may be prescribed, again, off-label. There's increasingly more research suggesting that stimulants may be helpful in apathy and dementia. Non-pharma approaches should be tried first, like music therapy, group art therapy, cognitive stimulation. People may also benefit from doing creative activities such as music and art rather than working. They don't necessarily need to work with a trained professional. And I've been amazed, for example, by the power of movement on music. And I know Insight has done some research and has programs. People that were just sitting there, and then if you start to play music, they get up and dance. I've seen this even in the office and the clinic appointment, and seen it on videos that caregivers bring in. So we need to do more research and understanding of that. It seems pretty clear to me. Again, don't take it personally and offer encouragement and gentle persuasion. All right, so the Libby study is a study, an NIH funded multi-center trial testing a THC CBD oral combination for the treatment of agitation, very common symptom of agitation at the end of life in dementia. Our primary endpoint in the study is to see if the study treatment will reduce symptoms of agitation as measured by the Combs-Mansfield Agitation Inventory compared to placebo at 2 weeks. What we aim to do is see if this THC CBD oral combination will help ease pain and suffering. We're taking a very close look at reducing caregiver burden. We're going to be measuring caregiver burden both qualitatively and quantitatively. We want to know if we can reduce burden and patient suffering. We want to discover a safe and effective treatment option for agitation at the end of life dementia. The commonly used medications that are used in hospice have never changed since the 1970s. They have side effects that often make the agitation and other symptoms worse. We want to see if THC CBD can help reduce the use of those medications, increase confidence in end-of-life decisions, and help future generations. So key eligibility criteria for the Libby study have to be in hospice or hospice eligible. Unfortunately, the hospice eligibility criteria in dementia, although it's common to be in hospice, it's not well defined. So we need to better understand what makes someone with dementia better for hospice, but we have more liberal criteria. So you don't have to be in hospice, but you have to be hospice eligible. Have to be agitated. Doesn't have to be real severe agitation. Score 4 or more on one of our inventories, but you could have agitation that occurs once a week, but it could be very distressful when it occurs. Have to have a diagnosis of dementia. Again, any dementia, not just Alzheimer's disease. We're starting at age 40 and older because dementia can occur very early. We don't want to exclude people who may be dying with dementia at a very early age. And you have to have a study partner. And
Up to you. How long is it?
3 minutes. Okay. I'm going to show you a short study summary.
Life stages can last from a few days to several months, and a primary goal is to ease the person's pain and suffering. These final stages can be unpredictable for people with dementia, and agitation is a common symptom. Inspired by the story of Libby Stofar and her family's experience with care at end-of-life stages, the lifespan benefits of cannabidiol and tetrahydrocannabinol, or Libby study, hopes to provide a different option for treatment. Funded by the National Institute on Aging of the National Institutes of Health, the Libby study seeks to learn if an oral combination oil of THC and CBD can safely reduce agitation in people with dementia at end-of-life stages. The Libby study seeks participants that are in hospice care or are eligible for hospice care, show symptoms of agitation, are over the age of 40, have a diagnosis of dementia, are able and willing to take the investigational treatment as instructed, and have a study partner throughout the study. Participation in the Libby study will require a screening process to confirm if someone is eligible to participate in the study. If eligible, the person will participate in a 12-week treatment period. During this treatment period, the participant will take the investigational treatment or placebo in the form of an oral oil and keep a study partner who will participate in in-person and telephone visits. The placebo looks like the investigational treatment, but does not contain any active ingredients. To learn more about the study and its inspiration, visit the study's website at libbystudy.org. On the website, you can also view the Find a Location page, search and contact the nearest study location. Visit libbystudy.org or call 1-800-LIBBY-11 to connect with the study site.
All right, and again, just finally with the Libby study, we'll be going to the person's place of residence. They are not coming to our clinic study visits, either in an inpatient hospice or at home or in an assisted living. That is it. I guess I'll stop share.
So we have some online questions.
Yes.
Please address how to handle keeping a patient safe when they have agnosia, how to best address communicating without coming across as the parent.
Yeah, so, so some of the same techniques that we talked about. So agnosia, the inability to identify objects despite intact sensory function. So for one example, keep things uncluttered. So if someone's looking for something on a table, don't have the table cluttered, then it's gonna be harder for them to sort it out. Don't ask them to go into, say, get something from the refrigerator where it may be hard for them to see it. It's gonna cause more frustration. So keeping them safe, some of the same recommendations that we talked about, and putting away dangerous objects that they may mistake for something else.
All right, our next question. If the loved one does not respond after 90 seconds, is there another recommendation waiting time for a response?
Now I wonder what this is. Is this someone with severe dementia who's not giving an answer, or it would depend on the reason why they're not responding.
Yeah, usually the steps we tell is ask a full question. If they don't, simplify it. The last one's a yes or no. So if they're not responding to the yes or no, then there might be something else going on, right?
Yeah.
Yeah. Next question. My husband often becomes very sad and weepy after a visit with a family member, convinced this person has died or that he'll never see them again. Especially challenging when he wakes me up at 4 a.m. I tell him they are fine and we will see them in a few days, and he seems to understand, but then starts weeping again 5 seconds later, again sad that they have died. Any suggestions?
Provide reassurance. I know that must be very sad, but they'll be back again, unfortunately, you have to repeat a lot of things over and over again. And I also know that can be very frustrating for caregivers. Melissa, do you have any other tips?
I mean, it opens the question, do we need to look and see if they have depression and do they need something to be on it? I'm not a med pusher, but it may be that weepiness is
something that could respond
with
an antidepressant. Yes. Yeah.
It may be something to help to sleep at night,
Exactly.
maybe doing the melatonin, and then he won't be waking.
And then some medications, some antidepressants are better. I mean, sleep is a very important. I could just include all the symptoms in this talk.
Yeah.
But some medications, we're always going to ask how the person's sleeping, because, for example, some antidepressants are going to be better to help someone sleep. Some are better with appetite than others, and so on.
What is the best way to get a loved one to remember today's date? How important is that?
It's not important. I remember way back in the 1980s, I worked in one of the very early Alzheimer's treatment centers. And we thought back at the time that it was very important to constantly reorient people, that was going to be the way that they would help remember. It's not important. You can, I mean, it may be discouraging to them not to know. So having a calendar and pointing to where they can look up the date can be a good idea. But the fact that they don't remember it is not important.
Okay. And how do you handle binge eating, especially if someone's diabetic and they keep grabbing sweets?
Yeah, that's a tough one. And one of the best things is to limit the amount of sweets that are in the home, but keep snacks and healthy snacks in the home. And providing a well-balanced diet so they're not feeling hungry, and having, lower calorie snacks, I think is the best, but that can be a tough one. I mean, they're all tough.
How do you handle someone who becomes agitated in the car, takes off their seatbelt, wants to go home after a short time?
So this is also a really tough one. I know in situations where couples would always take a vacation and go in the car, and sometimes it comes to the point where it's definitely not safe to be alone with the person in the car, or you have to stop the traveling longer distances, because that's really, I mean, having someone the potential to even open the door or become agitated is not safe on the highway. It's only the driver and the person. So sometimes having another person in the car can help. Sometimes giving medications like trazodone that help with anxiety before a trip, but you wouldn't want to do that the first time right before the trip. You want to have them take that and see if it's effective. I do have a person who travels to Massachusetts, and they, severe dementia, they use THC that they get, recreationally, I guess it's medicinal use in Virginia now. I can't recommend that, but CBD is another.
An easy trick I've used is putting on their favorite music in the car. So they're focusing on the music and singing to it.
Yeah.
But I mean, this can even be to doctor's appointments, and I've had clients do that as well. And it comes down to, do we need to start bringing the doctor to the house and having in-home visits? Because sometimes it's just not safe to be taking them in the car, period. So
Yeah.
one last question online, and then we'll grab the in-room people. The person thinks they have no symptoms and therefore think they have good judgment when they don't have good judgment.
Yes.
So we deal with that a lot.
Yeah.
Okay, questions in the room?
Hi. Thank you for all your good help.
How are you?
A large problem that I have with my husband is when we have an appointment and we have to leave the house in enough time, he has a problem walking too. And it seems like when he senses that I'm a bit in a rush, he slows back down. We'll find little things to do. And how do I deal with that?
One thing is, try not to seem like you're in a rush. So, allow more time, in the morning. It's interesting to me that because oftentimes if someone senses that you're in a rush, they're also gonna get more agitated and frustrated, like he slows down, like it seems purposeful, like he's trying to sabotage you in the appointment. I think the best thing I can say is, try to allow more time and try not to seem rushed.
That's what I had to do, allow more time.
Me too.
When I lie and say you have to be ready at such and such a time, then I give at least 45 extra minutes.
Yeah, that's a good tip.
Yeah.
Because when I'm rushing to get ready, it makes you more anxious.
Mhm.
So I'm into lying. Okay.
I mean, you think about it, these things happen outside of dementia too. I know when my husband's anxious about a time, he's racing around, like Sean Man, I get more anxious too. So it's just exaggerated and
What do you do when you just ask a simple question like this morning? My husband's, my brother-in-law's with him right now, which he's fine on his own for now. But, the pillow was missing on his chair and I just said, where's the back pillow? He gets very defensive, or just put it over there because it's gonna, and he gets angry because it's hurting my back instead of just saying, it's over there. He gets angry at me if I ask him a question. That's really frustrating. And I try to walk away most times.
exactly, that's what I was gonna say. If it's not important, try to walk away, take a break yourself.
Because if I say to
breaths.
him, I don't care, I just want to know where it is.
Yeah,
Then
that's,
I'm adding to his frustration and then he gets more mad at me or he'll say, okay, mom, that's his first thing.
yeah.
When you think about it though, when you ask that question, you're pinpointing that he's forgetting where something is, even though you didn't say that. But to him, it's, oh, you're questioning where I put it and I can't remember. So now I'm mad at you for pointing out that I'm forgetful.
Yeah.
So maybe not even asking the question would help prevent that. And you just have to look for it, and you're going to turn into Sherlock Holmes finding things in shoes and refrigerators and who knows where else.
Because he gets very sarcastic about it,
Mhm.
and gets mad.
Yeah.
and
Right,
upset.
doesn't like to be
Yeah.
challenged.
No, not at all. He doesn't like to be asked anything. But I wanted to ask you also, he takes sertraline, he takes that in Aricept. Is Aricept, does that help at all, do you think?
Yes, Aricept is, a cognitive enhancer. It's been proven effective in mild, moderate, and severe disease. In our clinic, we continue patients on Aricept until they either can't swallow it or can't afford it.
Okay.
Is that the same as Don's show?
It is.
Yeah.
Oh, yeah, that's what I have, the
Yeah.
Don's,
It's
whatever.
not been proven effective in mild cognitive impairment.
And the last time we saw the doctor, the neurologist, he did up the sertraline
And
to help.
sertraline is, I think, one of the most common antidepressants that we use in our clinic, for depression.
Xanax, right? Xanax.
Something like that. No. We try not to use, Xanax belongs to a class of, but they are commonly used, for agitation. called benzodiazepines, and they contribute to increased risk of falls and can cause increased confusion. And oftentimes when they're taken, they don't, their effect is not when the behavior is occurring. So they tend to be unsafe for people with dementia, but
Right, someone told me it was the same, and I don't know much
It's
about
very
it, so-
addictive.
So,
Did you
Very
repeat the
because I know
name
of
of that again?
Xanax.
We had those.
It's not forget.
That's not
Sarah,
Xanax.
how do you pronounce Sarah Trailer? Sarah.
Sertraline
That's
is,
what it
it
takes.
belongs to, sertraline is a selected, it's an SSRI. It's an antidepressant.
Okay,
Xanax is a benzodiazepine or
Oh,
an
right.
anti-anxiety medication. Ativan is another common benzodiazepine that's used. Sometimes it's used for sleep, but you know, like to try to prevent people from taking the Xanax and the Ativans, but not the Ariceps and the Exelons. Now go ahead. Okay. I think we have time.
But my husband is diabetic and he wears a sensor, but he takes it off whenever he feels like it. Any suggestion?
If there's anything you can do to find out, first of all, why he's taking it off. Is it uncomfortable? Is there something like if you covered his arm and he didn't see it, like he had a long sleeve, does it happen less? Is there anything like,
No, I've tried the long sleeve because he's
Can you put it on the back of his shoulder right here where he can't reach it easily? Because my husband has something that he has to get that.
I've been trying that.
how do you attach the sensor?
Comes in a attachable thing and you just click it on.
So it's easy to move around. It's easy, like,
You put it on once a month, right?
that's.
No, every 14 days.
14 days.
So it's not so easy.
And it probably has to be on muscle, so I don't know if it could go on his back. I would ask the doctor and see if there's another place they could put it. I think they would be the most helpful for you since they know the device the
To make
best.
sure it's not causing irritation to his skin, that's not the reason why he's taking it off. Maybe there's another type of sensor that might work better for him.
I'm not sure. I've asked the doctor and she sticks with the one that he has, but it works.
Yeah,
And
he's
he's
getting back to
getting
you. I mean, all these are just suggestions, but now there's simple solutions.
Face bandage
Yeah.
around it?
Yeah, that's an idea.
Yeah.
Wonder if that would.
You know, because he'll take that off.
Take it off, too, yeah.
And he just recently started doing this. He wasn't doing, he's been wearing it for over a year now. And no problem. And now when I go to scan it with my phone, like this morning I went to scan it. He said, there's nothing there. I said, what happened? I took it off. I said, it's not time to take it off, you know, right. And they're very expensive. And
So we have a bunch of questions online now.
I bet you it was OT.
Is there really, we don't have for my father a specific diagnosis. So he has dementia, it's pretty clear, and he's on Aricept and the other Memento or whatever, the other drug. Is there a reason to get a specific diagnosis? Why? So
Well, because the dementias, have different treatments. So Aricept is typically not used in the other dementias. It's much more, I mean, it's indications are in Alzheimer's disease. But I think it's really important to ask the provider, what is the dementia diagnosis? And if they can't answer that question,
he's deflected it to, that would take a lot of testing.
He
It
said
doesn't,
it's not necessary.
yeah.
This was a neurologist.
Just
so-
say,
I think it's
Just symptoms.
You see this all the time. You know why it's particularly important right now? Because we now have disease modifying treatments. And people, which the first one was approved a couple of years ago, but it was controversial, but this year, lecanemab or Leqembi was approved. And you have to either have a diagnosis of mild cognitive impairment or mild Alzheimer's disease to be a candidate for this. And if you have a diagnosis of dementia, then you would not be a candidate. The person, and it might be something that the person would very much like to consider. We've been waiting for years and years for disease modifying treatment. We have Aricept and cholinesterase inhibitors. They don't work directly on the underlying pathology, but so they're not in this sense, they help alleviate the symptoms, but they're not disease modifying. Over the long run, they're not going to impact the course. But with all of the dementias, the treatments are different. We finally have a disease modifying treatment. We're gonna have even better ones coming up
Yeah.
even this year,
Okay.
which are more convenient to take. Because Leqembi is gonna be dosed every 2 weeks and it's an infusion. It's gonna be a lot for a lot of people. But I would challenge the provider and to give it, sometimes providers are still not doing it because they think people don't want to hear it. It's
Yeah.
hard to
Yeah.
believe, coming from both neurologists, I'm more surprised, primary care physicians, then remember these are very busy practices and they're not taking the time to do what it takes to give a diagnosis, but all of that has to change, starting to change now with the new disease modifying treatments. We have to have better educational efforts.
What's entailed in the testing?
Well, now the biggest advances are in terms of better biomarkers to diagnose the disease. So we're going to have right now, so you can make a diagnosis based on history. It's probably, I would argue, one of the most important aspects of a diagnosis. How did things present? What symptoms presented and how did they progress? Then you also need to get an MRI scan to rule out other things that could be contributing to the person's memory. You want to rule out reversible causes of dementia, things like B12 or thyroid. So there's a basic set of blood work that you get. So you do a physical exam and make sure there isn't evidence of other types of dementia. Because Alzheimer's disease typically doesn't have physical symptoms. So you want to, has the person had a stroke? Do they have a tumor? Are you going to pick that up on the MRI? But now the blood biomarkers, so now the best way, amyloid is the biomarker of what we can measure in the brain that rises first. It's a clumpy protein. It rises 10 to 20 years before the onset of memory loss. So in order to be a candidate for, now we can measure it in the PET scan, but very soon we're going to have a blood test. It could even be a 2024 an FDA approved blood test. All you have to do is go in and get your blood drawn. It's going to tell you your amyloid level. And that's going to be great, especially with these new treatments, because we're not going to give them to people who don't have elevated amyloid. And right now, gold standard is still the amyloid PET scan. And also or a spinal PET. You can measure the proteins, amyloid is how in spinal fluid or by a PET scan, and very soon look out for new information about blood biomarkers because treatment has to be started early in order to be most effective. So you don't want to wait till people have advanced problems. They're not going to be a candidate for the new treatments. And the damage that occurs in the brain accumulating, if you think about it, it starts 10 to 20 years before any symptom at all. Already by the time you have symptoms, there's damage that's been done, and none of the new treatments are expected to reverse damage. The goal is to stabilize decline, and the new medication stabilize Leqembi by about 26% per year. It's not enough. You know, it's not a cure. So we're going to have new treatments every month.
What is the other medication that's coming along? It starts with an M?
Donanemab, D, right?
Banana?
It's called donanemab,
Okay, because
and they haven't given it.
Okay,
They have not given it a trade name yet, so it's still
No.
got that long name. It's donanemab by Lilly, but they don't have that. They're skipping the accelerated approval process to go in straight for approval.
so to be eligible for the Leqembi, would you have to have a PET scan?
Yes.
Because the
Or
neurologist mentioned it, that he wants my husband to have blood work because there's something in the, if you have something in the blood, would not even qualify to do the trial.
You don't qualify if you have, if there could be something else in the blood, like a low B12 or a thyroid. You have to have had basic. Yeah.
If we can take the med question offline, 'cause I've got 10 questions on here about behavior, since that was our topic and you guys can talk.
Sorry.
No, that's okay. Yeah. Suggestions on how to deal with aggressive behaviors when trying a different activity is not possible. For example, when you need to clean them up from a toileting accident, then you really can't take them anywhere else until they're clean and dry.
Yeah, so this is another thing, abundance of patience. You have to give them breaks. You know, you have to wait if they're very aggressive and you're not going to let you, you may miss the appointment. Find something that might soothe them, that would allow them to carry on with the activity. And this, if it's happening a lot, of course, eye medications to help with agitation. So again, the antidepressants, or we often use trazodone as needed. if you know something's coming up.
How can I remind my mom to sit and change her clothes so that she doesn't lose her balance and fall? She's had 7 falls this year alone.
Oh, gosh.
She needs to be, first of all, supervised,
Yeah.
constant supervision, which is hard to do. You need help. And you probably need, in this situation, you probably need to hire help from outside because and you want to look at the cause for her fall. So make sure, why is she falling? But someone who's really, and physical therapy can often help to reduce the risk of falls.
Another one on toiling. Toiling is a huge issue for us. Confusion is profound as how to use the toilet and sit down. Any suggestions?
So apraxia is when you lose the ability to know how to do known tasks like toileting. Suggestions are well lit on the way to the bathroom, supervision when people are toileting, raised toilet seat. And again, if people don't remember what the purpose of wiping is, they're not going to wipe, they're not going to wash their hands, so they need to have supervision when they're toileting. Timed toileting can help with incontinence, taking someone to the toilet every 2 hours, even if they say they don't have to go.
And I think don't ask, say, we're going for a walk. We walk them in, we're going to sit down.
Oh, I like that.
Yeah, because a lot of times they might be saying no, but that's not what they mean.
Right.
So I just went for a tour of adult daycare. Husband thought he was going to help the participants there rather than be a participant. He has no interest in going. How can I sell daycare for 2 days a week, or should I? We actually encourage them to come be volunteers, and he can come be our helper. So I think that's a great way for him to look at it. We have lots of people that think they're volunteers,
Yeah.
and they are helpers. So I
I've
go
used
with
that
it.
strategy a lot. They really could use your help.
Yeah.
And that is true in many cases, right?
Yeah.
They're not, I mean,
My husband consistently slows his walk to taking menacing steps toward the restroom, despite having said he needs to use the restroom. I get quite frustrated with this behavior. Any thoughts on why he is occurring? And is it all common in moderate disease stage?
so what's he doing? He's
He's shortening his steps and getting slower.
On the way to the bathroom only.
Yeah. The fear, I don't know, may have a fear of falling or having an accident, so he's trying to hold it in. It would take watching it, I think.
Yeah,
Yeah.
sure. What's going on? See, it's unusual to purposely slow steps on the way to the toilet.
Yeah.
Does it happen at any other time?
Yeah, I don't know. It's just not.
It could be any directed activity.
Yeah. How do you handle aggressive behavior at the point that it's violent?
First of all, call 911 if it's an emergency. Get out of the house if you feel like you're in danger. That's number one. Block away. Make sure they don't have access to dangerous, objects like we talked about. Make sure there are no guns in the house, no knives, anything that could become a dangerous object. And this is a situation where I think medications and working more closely with the treating provider that how to control the behavior. So any medications.
And it could be signaling they have a urinary tract infection with that drastic behavior change too. So get a urinalysis.
Yeah, always for infection.
Yeah. Have you found that Parkinson's dementia is grossly underdiagnosed? Also, I've experienced that dealing with dementia requires the patience of a saint.
I'm sure. Yeah. I don't know. Wouldn't say that I felt it was underdiagnosed. The dementia in Parkinson's, if it's Parkinson's dementia, it occurs much later than the physical symptoms, this associated shuffling. But I don't know. I do think it's evaluated and diagnosed. I don't know if it's underdiagnosed, but Alzheimer's is certainly underdiagnosed though, so I guess I shouldn't be surprised. It continues to be underdiagnosed.
Do you encourage a DAT scan?
For Parkinson's.
What is this?
Not
DAT.
Alzheimer's
Yeah.
disease.
And then you were talking about diagnosis and the golden standard. Amyloid, CAT, or a PET scan, would you say?
I don't know, but I don't even know. I'm not aware of an amyloid CAT scan, an amyloid PET scan. That, which is different from a glucose PET scan or an FDG PET scan, which maybe the person was thinking of.
I got an answer to that question of this, the walking thing to the bathroom. That's the only time he does it.
Well, that's a tricky one.
Yeah, that is a tricky one.
I mean, is it causing him to have incontinence too? So
Yeah.
it's going so slow, so that he's having incontinence.
Maybe by the time he realizes he needs to go, he's already leaking. And maybe that's why he's going slower, so that he doesn't have an accident. So do we have a scheduled toileting plan? Are we using, depends, if he won't wear those, there's washable underwear that is actually padded that can collect all the urine, so he still feels like he's wearing underwear.
Oh.
Check that one out.
So
Or
that's
maybe it's hard for him to get down to the toilet seat,
Yeah.
so a raised
Yeah.
toilet seat.
Maybe he's having pain when he goes to the bathroom. Could have a urinary infection.
And then, do they know?
Maybe he has a fear of going to the bathroom because it hurts. Maybe he's constipated.
So maybe it's just the process of having to unzip and pull down and all that process, yeah.
But this is an example too, so all of you are giving each other equally the same amount of advice that I'm giving, so that's why the support groups and the memory cafes can be so valuable.
And the last one's a comment. Marymount University through Insight is offering a study for people with Alzheimer's and balance fitness. Husband has been enrolled for 4 months, once a week in the study. It has helped prevent falls through the balance activities. I highly recommend signing up. So if anyone wants to reach out to me, people in person, my card is here. I can get you the information. Those online, it's I put it in the,
Is that by Dr. Julie Reese?
yes.
Yeah, I'm very
Yeah.
familiar with that, yeah. So excited.
But you guys can reach out to me at melissa.long@insightmcc.org, and I've also put that in the Q&A.
You mean you?
Yes, and I can get you the information. Yep. So
Yeah, she is looking for people. It's hard for me to believe how hard it has been for her to recruit.
Yeah.
Because it seems like how ideal. They'll come out to the home and do the evaluation. Sometimes it could be because people are less responsive to activities online, but you do it with your care partner and another couple. So she's testing whether this balance intervention will help prevent falls, which are, you know, a big cause of morbidity and mortality.
He knows they're doing the George Mason one too.
Yes.
He's in that.
So, before we end, I just want to remind everyone, we have many events online, in person. Please go to insightmcc.org/events, and you can see what's next. Next month, we'll be talking about physical activity and how it benefits your cognition at our care partner presentation. Thank you again. There's my contact information if anyone would like to reach out to me. We did record this. It will be put online. And we are more than happy to answer any of your questions that may pop up with other behaviors or questions about your dementia journey. So thank you for having us, and we wish you all a good day.
Thank you. It was very good. Thank you very much.
Thank you all for coming.
Thank you very much.